So we move on to the next part of the session, which is the panel discussion. This session would be moderated by Dr. Kalpana Das ma'am. Ma'am, please come to the dais. Dr. Kalpana Das ma'am is the Chief of Diabetes and Endocrinology at Apollo Sugar Clinics, Raipur and Bilaspur. She is a Senior Consultant Endocrinologist at Apollo Hospitals, Bilaspur. She is also the Professor of Endocrinology at Apollo Hospitals Education and Research Foundation and a Senior Consultant at Narayan Rudalaya, Raipur. She has multiple publications in national and international journals, and she is an active member of multiple diabetes awareness societies. With this, I would hand over the mic to Dr. Kalpana Das ma'am to moderate the panel discussion.
Hello, thank you very much. First of all, I must thank the organizers for having me here. So after gaining so much of knowledge on endocrine oncology, let us just move on to the next topic. That is a very good panel discussion on endocrine issues in women cancer survivors. As you know, the survival more than 5 years after the cancer diagnosis, that has significantly increased because of the advancement in the diagnosis and the treatment. And this can cause many long-term sequelae apart from the endocrine sequelae. And all the endocrine sequelae are because of the hypofunction and some local effects. That could be because of the tumor itself or because of the radiation therapy and chemotherapy, immunotherapy, and surgical therapy. So there are many dysfunctions, especially they affect the hypothalamic adrenal function and thyroid axis, parathyroid hormones, and pancreatitis 7, and gonadal function growth disorders. So we have with us national reputed speakers and the panelists. So I will request them to come onto the dais. First is Dr. Jayashree Swai, who is a professor in the Department of Endocrinology at IMS Sam Hospital, Bhubaneswar, and she is my, I would say, is a younger sister to me. And she has number of original research publications, about 12, and there are 2 achievement awards. That is RSSDI Best Innovator Award in Diabetic Care in 2022, and she also has a certificate of appreciation from Department of Health and Family Welfare from Government of Odisha for Diabetic Training Program 2015 and 2016. Please have a seat, Jayashree. Huh? Yeah, okay. And second, we have the second panelist, that is Dr. Belinda George. She is from Bangalore. She is an associate professor in the Department of Endocrinology, St. John's National Academy of Health and Science, Bangalore, and she has completed her MBBS, MD, DM in St. John's Institute. Her area of interest is adrenals and gonads, and recently she has published a work on 46XY disorder of sex disorder due to 5-alpha deficiency, experience from multidisciplinary pediatric gender clinic, journal of pediatric, and there are many works also. And the third panelist is Dr. Savita Goswami. She is from Kolkata, and she is a clinical psychologist and a psycho-oncologist and is in Tata Memorial Center. She is working since 1996 in TMH, and area of interest is survivorship and palliative care, spirituality in cancer. So I will divide some questions. We'll be discussing some endocrine sequelae. So we don't have Dr. Deshmukh today, so we have 3 panelists at the moment. Some questions I will combine and ask them. So let us have the first question. I will ask to Dr. Jayashree Swai. How commonly do you face the endocrine issues in cancer survivors, and which cancers commonly do they occur? And the commonest endocrine problems, and do they vary according to age groups? This is for Dr. Jayashree Swai. Jayashree, please.
Good morning, everybody. Thank you, organizer, for giving me this opportunity. Thank you, madam, for this, Kalpana madam, for this nice introduction. So, coming to this topic, endocrine issue, we are frequently facing this endocrine issue, encountering the endocrine issue in our clinical practice. And as it is this sequelae of the primary disease itself, or there is modalities of treatment, sequelae of the modalities of treatment, or there is a long-term effect of this disease or these modalities of the treatment which is affecting these persons. And as you know, this cancer incidence is increasing day by day, and 14 millions by this year 2012, it will increase to this 20 million by 20 per year by 2025. And data from US study, there is a decrease in the cancer survival is increased. Mortality rate is decreased by 26% from the USA study. So we are getting large number of these patients. They are cancer survivor patients. Long-term survival is there. And also, let's see if I quote some study that is defined and al. From a Scandinavian study. These endocrine issues are 4.8% higher from these general populations in these cancer survival patients. And also the cumulative incidence rate is 48% by this age of these 60 years. So definitely this risk is increased, and this common malignancies which we are seeing, that is this childhood malignancies, survivor of this particularly ALL, and also hematological malignancies, and in female that is breast cancers, and cervical cancer, endometrial cancer, and also there is a long list, that is the thyroid malignancies, and also that malignancy after these radiations, lungs cancers, and GI malignancy, and genitourinary malignancy. There is a long list of the things of these cancers, and there is increase in these cancer survival patients. So endocrine issues are common.
Thank you, Jayashree. If you can put some light on the Danish population study, that is regarding the cancer survivals in the young adults and adolescents. How common is the growth disorders and the gonadal disorders in those population study? If you remember, if you can look back.
Particularly if young patients is exposed to these cranial irradiations, they may have this GSD, growth hormone deficiency, and along with that multiple pituitary hormone deficiencies are there, and hypogonadal, and subsequently at this means if you look to this endocrine organ involvement, there is acute involvement may be there. There is steroid-induced hyperglycemia, hyponatremia, radiation-induced thyroiditis, and other things. And in chronic, long-term, late effect, there may be gonadal effect is more. That is in the tune of this 40 to 50% gonadal effect in this adult survivor.
Yes. Thank you so much. If anybody has any questions regarding this. So next I will move on to the next question. Is there any, this is for Dr. Belinda Jas, is there any tips or advice to prevent or minimize the endocrine issues among these cancer survivors? Because basically what we want to know, that if we know early so that we can prevent them, we can assure them, and we can rehabilitate those patients. So this is the main motto of our panel discussion for our patients.
Thank you, ma'am. Thank you for that question. So when it comes to endocrine diseases, when we talk about prevention, like ma'am said, early detection and identification of the problem is what is key. So if you know what underlying cancer the patient had, and if you know what therapy the patient has received, you will somewhat know what are the problems to be expected in this patient. And also, like in the previous talk, Dr. Joe had showed in the end, predictors to decide who is likely to develop a complication. So that is where we are slowly moving towards. We may not have anything with us today for utilizing in precision medicine, but going forward, probably you will be able to identify who are the patients who are susceptible to develop certain deficiencies as a result of the therapy that they have received, and so we can focus and be more aggressive in screening them. So one way to identify early, of course, is to have screening programs. So every cancer patient, depending on what therapy they have received, there are set guidelines, like we were discussing in the previous, how frequently to check thyroid, how frequently to check for cortisol deficiency, how frequently to check for hypercalcemia, hypocalcemia, etc., which should be done. In addition to that, when we are talking about pediatric cancer survivors, because we do see a lot of children who are coming with growth and pubertal disorders, so there something that we can do as endocrinologists is to monitor them very closely. without any major investigations. So if we get the referrals on time, we can actually monitor their growth velocity and pick up a GH deficiency much before and initiate therapy early and intervene early if necessary, because early intervention will obviously, we'll have better results with early intervention. Similarly, if you feel that the child is having delayed puberty or precocity, again it's easier for us to intervene if we pick it up early. So either precocity or gonadotropin deficiency can occur depending on the amount of radiation they have received. So all of these can be picked up by simple clinical examination. So majority of the things will be essentially by screening, and of course some of them you will have to depend on biochemical screening as well.
Can you give us some tips how to prevent these issues? And what is the role of genetic testing in these issues?
The other one, ma'am, that I forgot to mention was with regards to hypogonadism. So if you are treating somebody with a drug which could be gonadotoxic, then fertility preservation is an option that we should discuss with the patient beforehand, before initiating chemotherapy. So at least in males it's relatively easier because we can do cryopreservation of sperm and then use it later in life. In women it's a little bit more trickier because it's not that well established. It's not easy for us to, retract a worm and store it. However, there have been studies which looked at gonadotropin GnRH therapy during this to send the ovary or the gonads into a quiescent phase and can protect it to the best ability possible. Apart from that, ma'am, so genetic tests, more than endocrinologists, I'm sure a lot of oncology team, they do a lot more genetic tests. And yes, if we can detect patients who are more susceptible to develop a deficiency disease or an issue, we can of course screen them in a much more aggressive way.
Okay, thank you. Any comments from the floor? If anyone can add anything? No, if you just hold this. Can you give? Can somebody?
I just wanted to, so you already know I'm, a health and medical psychology faculty at IIT Hyderabad. My question is centered around that part. So you were talking just now about fertility conservation, right? How do you start that dialogue with a young child and their parents?
With regards to, you're discussing fertility preservation?
Yeah, sorry, preservation. Yeah, how do you have that conversation?
Yeah, so essentially it will be not us, the oncologist who is initiating the conversation first, because they are going to be dealing with the issue up front. And of course, they will refer to us saying that, okay, so when the patient comes to us, they've already been primed about the fact that, the patient might be receiving a drug which is gonadotoxic, and what are the options that we have that we can help to preserve fertility in this patient. So I think maybe ma'am, if you want to answer. Or
Yeah, so I think the most important thing as an oncologist, we should remember to discuss this issue. What happens, when patient with cancer, both clinicians as well as patient and family, they are more worried about cancer than fertility. So as an oncologist, it's our responsibility to discuss this issue before starting any cancer-directed treatment. Also have multidisciplinary teams, so always refer, such a patient to their fertility is a issue to an infertility expert upfront before starting, because once we start any cancer-directed treatment like chemotherapy or anything, then subsequent preservation of gametes or whatever is not possible. So other thing you just mentioned about the use of GnRH while patients on certain chemotherapy, and that has been shown to be effective in breast cancer. So it's routinely recommended to do ovarian suppression in women who are receiving breast cancer chemotherapy, and that's been routinely practiced. So we start 2 weeks prior to start of chemotherapy. And also another important thing is to have baseline evaluation, especially for patients who have gynecological cancers. So at least what minimum we have to do a AMH level and at least ovarian follicular count if possible. So baseline evaluation before starting cancer-directed treatment, open discussion with the family and referral to an oncologist. I think these are the things we routinely do. And as you mentioned, for males it's much easier. But the problem is even, such a simple thing as semen cryopreservation, we often miss that. So the most important thing is everybody should be aware, because many times patients and family and sudden diagnosis of cancer is so devastating that in the this thing of cancer we also tend to forget. So it should be in our checklist. A young patient we should. In fact, we are planning to, of course, it's in discussion phase to have a clinical onco-fertility center in our hospital. So.
Thank you, madam. I just want to know, do we really freeze the ovum before starting the chemotherapy or radiotherapy in young ladies?
Yes, we try to, at least what is very important to have an infertility person right from the beginning to be a part of this care. They have to discuss, there are certain cancers where stimulation may not be safe, may not be possible. We have to discuss that. We also need to see the time in hand, like, if treatment has to be started immediately. And if, the minimum time required for oocyte preservation or ovarian stimulation, at least we need 2 to 3 weeks. So all of that, it's a complex thing. We need to check if that much time is there. We do refer all our patients to an infertility person, and we do oocyte cryopreservation if indicated. So some of our patients we have done. Of course, other thing is cost and other factors, and many young girls, then parents are also not very sure. So it's not all that easy. But what is very important, counseling and giving the information, and let patient and family make an informed choice to go for it or not.
Thank you so much.
Ovarian tissue cryopreservation is another option, but that is, I think, still, I would say it's in our country especially, it's still in fancy. So what is best is oocyte, gametes, embryo cryopreservation, oocyte cryopreservation, and then ovarian tissue cryopreservation.
Okay, thank you. Let us move on to the third question, that is for Dr. Savita Goswami. What are the tests required to identify these endocrine problems? Like the previous speaker, they said some of the endocrine dysfunction is because of the inflammation of the few glands like hypophysitis, thyroiditis, pancreatitis. So what is the time frame when we give such kind of treatment like immunotherapy? When should we go for certain evaluation? And other than the hypofunctioning of the glands, like somebody suppose treated with surgery, when should you evaluate for the hypofunctioning of the glands?
Hello everyone. Thank you organizers for having me here. Thank you madam for the question. So I'm a psycho-oncologist, so from my perspective I will answer this question. I work with the survivorship clinic, and I work with childhood cancer survivorship clinic since last 27 years. We all know that in childhood cancer survivorship guidelines are quite well established than adult cancer survivors. So you were asking about the test and time. So almost all the survivors, those who register in survivorship clinic, most of them undergoing screening test, and depending on the kind of treatment they have received, and especially cranial radiation, and those who have received previous high-dose chemotherapies, there is certain protocol, and annually they have been screened for that. So every year they come for follow-up, and all those relevant tests, depending on their type of diagnosis and kind of side effects they currently have. So screening has been done, and it is a multidisciplinary team. So we also do psychological evaluation, because it's not just physical testing, but along with psychological symptoms, like suppose somebody has mood swings, and suppose who had a lot of anxiety arousal. So in that case, we also assess them for thyroid functioning test and all those things, because anyway it's linked to that. But I would appreciate if somebody from medical side take that question and talk about it.
Should we wait until the patient becomes symptomatic, or it's just a yearly screening? Yearly screening may be for the hypofunction, but what about the thyroid inflammatory diseases?
I will add something with madam. That regular routine follow-up is necessary. It's very much important. Routine monitoring of this growth, routine pivotal monitoring by Tanner stagings, and that monitoring for the thyroid function checks clinicals, it is required. If somebody is having growth failure or there is a poor development of the secondary sexual character, at that point you can go for the growth hormone stimulation test or growth hormone dynamic test. And along with that, baseline FSH, LH testosterone is required, and periodically follow for hypothyroidism, thyroid function test is also required. All the things we can capture early by doing this regular routine follow-up. So I think Belinda will add something. Yes.
Same thing, ma'am. I think for hypofunction, for simple tests like TSH, calcium, all we can do annually. For pubertal disorders and growth, we can monitor clinically and evaluate if there is a suspicion. For instance, the child is not entered puberty in a girl child by 13 years or in a male child by 14 years, and I think we need to evaluate to figure out if there is hypogonadism.
Rightly said. Any comments from the floor? Yeah.
I think you should leave the mic at that table.
I mean, come on, Dr. Savita is a psycho-oncologist and she knows I'm a psycho-oncologist, so it's only natural I will ask her a question.
Sure.
Hi. I wanted to ask you, you know, the screening that you're doing for mental health outcomes and symptoms, what kind of therapeutic modalities are you following that up with? And not medical, but psychological.
I think Madam will be coming to those questions, but I will still answer those questions. Like for adult as well as for children, we have a different kind of setup, and those who are referred to us for all these issues who related to anxiety, depression, because everything is cancer brings lot of psychological burden. So psychological modalities, mostly we use cognitive behavior therapy, but mostly I think supportive psychotherapy helps a lot in oncology setting because it's more flexible, and even the time frame is can be flexibly approved, and that's why mindfulness exercises can be used in that. Meaning-centered therapy, acceptance and commitment therapy is very useful in this, because we have to address here and now approach. Cancer has long burden. It's not that within 2 years or 3 years the whole business will come to an end. They have to have many times on long-term follow-ups. And for long-term follow-ups, many times those issues will be addressed gradually as and when they come on the surface. So different therapies can be used depending on the intensity of the problem, intensity of the psychological issues. But of course, the tailor-made approach is very important because children will have their own issues, adults will have their own issues, and we have to see everything in our setting, like stigma related to cancer, the way people have attitude towards cancer, how they are making adjustment at their workplace. So they will be having their own set of problems. So all the therapies will be...
We'll discuss them later,
yes,
because we'll come to that.
So because the question has been asked, I have to answer the question.
Next we'll discuss about very important disease, metabolic bone disease, the osteoporosis, which could be because of the cancer itself or because of the anti-cancer therapy. So I have two questions now. This is for Jayashree. How common is osteoporosis in cancer survivors, and which cancers and anti-cancer agents they can cause osteoporosis?
If you look to the prevalence of osteoporosis, that is in the tune of 15 to 30% in the men cancer survival, and it is around 40% in the female cancer survival in premenopausal age, and more than 40% in the postmenopausal age. That is the prevalence. And the most important culprit cancers are these breast cancers and prostatic cancer. And we know this, briefly I will summarize these cancers. Like multiple myeloma, they have this direct effect on these bones, and also the breast and prostatic carcinoma, they have this anti-estrogenic, anti-androgenic therapy, radiations, they are causing this decrease this bone health and osteoporosis. And there is hepatocellular carcinoma and sarcoma, they are causing this osteoporosis through the PTH, RP related issues. And renal cell carcinoma, melanoma, thyroid carcinoma, and they are having this osteolytic metastasis. They are causing causing this osteoporosis or low, and if there is somebody is having irradiations, whole body irradiations like the hematopoietic stem cells transplantation, they may have the osteoporosis. And the culprit agent is the most commonly glucocorticoid, which was extensively discussed in the yesterday. And the cause of the osteoporosis, we all know that it has actions on osteoblast and osteoclast, though osteoclastic activities at the beginning, after that osteoblast, and also it has actions on the calcium homeostasis, and also sarcopenia is there, and it decreases the IGF growth axis, and also the gonadal axis is suppressed with the glucocorticoids. And along with that, methotrexate, which is nephrotoxic drugs and causing hypomagnesemia, some of the times there may be the interfering with the bone health. And also newer agent also immunotherapeutic agents are also responsible for the low bone health. And eposamide is another agent. It is causing the Fanconi-like syndromes, renal tubular acidosis, hypophosphatemia and osteomalacia in the adult. And also, as I have described, hematopoietic stem cells, radiations, and so many alkylating agents are responsible for this low bone mass, and also the osteoporosis in the children and adults.
Yeah, very well said about the causes. Next I move on to the, how do you screen them? The screening method is same as the normal osteoporosis, or it is different? And how do you screen them? How do you prevent this?
So ma'am, when we talk about cancer survivors, generally the commonest cause for osteoporosis in them will either be related to the drugs that they have taken, which includes glucocorticoids like ma'am said, or if they develop hypogonadism as a side effect of their therapy, then again that will predispose them to develop osteoporosis. Or maybe if the malignancy itself is extending, they may have metastatic lesions which will predispose them to fractures. So these are the three main categories. So if the patient falls into a high risk category, then it makes sense to screen them early rather than wait till the general recommendations. So if you have a patient who's hypogonad, then yes, it's important for us to address bone health as well. How do we assess? It's very similar to how we assess in other scenario. The best tool would be to start off with a FRAX scoring, and if the FRAX scoring gives a high risk, then we go ahead and get bone mineral density testing done. And depending on that, you can decide whether to intervene or not. So just one line about the drugs. The common drugs that we use are bisphosphonates and now denosumab. PTH ideally should be avoided, even though the boxed warning has been removed from PTH for osteosarcoma, and we do not have any human data with regards to osteosarcoma. I mean, not data, we don't have any reported case of osteosarcoma, but still in a patient who already had a malignancy, it would be prudent to avoid an anabolic agent like PTH. So most of the therapy will be using bisphosphonates and denosumab. Of course, we should not forget to replace adequate vitamin D and calcium, and also encourage the patient to have good physical activity, because that will also strengthen the bone and
so
prevent
for every
osteoporosis.
patient you have to give vitamin D and calcium
Vitamin D and calcium,
supplementation.
if they have risk factors for bone
Is the
disease,
dose
yes,
same as
definitely we have to.
other cases, or the dose is something different, vitamin
It
D?
would be something similar to giving in patients who are at risk for osteoporosis. So
Do you really
it would
need
be
the normal vitamin D or the active vitamin D3?
just the regular vitamin D is
Regular
adequate,
vitamin
ma'am. We
D3.
don't have to replace calcitriol in any of these patients. Just simple
Done.
cholecalciferol would
We are
be
running
adequate.
short of time. So this is one question to Dr. Goswami. Do you really explain the patient psychologically that these drugs can affect our bones? How do you explain them? And how do you explain them what kind of symptoms if they do have, they should consult with the doctors?
When patient come to us, many times they have fatigue and pain. These are the common complaints in survivors. So we identify, we see we have our own screening, psychological evaluation, and in that many times we realize that these are all physiological complaints which many times they need to go back to their parent unit and they should take advice for that. So we counsel them accordingly that certain things they need to be monitored and seen by their physicians, but definitely we counsel them about their lifestyle management and how they can modify their daily routine activities. Risk-taking behavior should be controlled in that case, how they should take regular medicines if those are advised, and also the food and dietary habits, which is very, very important.
Okay, thank you. This is just one general question to the floor. Should we ask, I want to know from the oncologist, if at all somebody is there, should we ask, do they ask for a regular DEXA scan every yearly for any onco patients who are undergoing therapy? We of course do it, endocrinologist, but what about the oncologist? I think we should go for DEXA, regular DEXA screening, and even the treatment protocol also, that should be followed by the oncologist. So next we move on to the next session, that is obesity, metabolic syndrome and diabetes. This is very important. As I said, there can be pancreatitis and there are other things also. So we can have obesity, metabolic and diabetes. So the first question goes to Jayashree. You should be very short, okay? We don't have time. What is the prevalence of obesity, metabolic syndrome, diabetes in cancer survivors, and what are the culprit cancers, anti-cancer agents that causes these syndromes?
In cancer survival, the prevalence of these three, obesity, diabetes and metabolic syndromes is approximately 50%. And the culprit cancers are the ALL, breast and prostatic carcinoma, and the culprit agents may be the cisplatinums, alkylating agents and anthracyclines, and so other glucocorticoids and other agents may have this effect in the long run to cause diabetes, obesity and these metabolic syndromes. And if you look to this mechanism, that may be these damaged radiations. If there is radiation to this abdomen, there is damage of this pancreatic tail of this pancreas, and also radiations causes this inflammatory, there is a loss of this subcutaneous fat in these abdomens, and there is a propensity for the depositions of the visceral fat, and that causes the chronic inflammations and also visceral obesity. And hypogonadism and growth hormone deficiency is the cause of this obesity, diabetes and metabolic syndromes, and we all know.
Just a quick question to Belinda. Are they preventable? Just one question.
Yes, ma'am. So I think we should, if the patient does not have any metabolic disease, I think it's important for us to.
Is it permanent or temporary? The diabetes in such kind of patients.
If it's glucocorticoid induced, it's likely to be temporary, and it can actually reverse
Do we
itself.
need to give only OAD or insulin? What is the best treatment?
Depends on the degree of hyperglycemia, and yeah, so.
So the final is psycho-oncology. I think the psycho-oncology, the psychologist has the major role in managing all onco patients, because counseling, and in endocrinology we need only education and education. So these two parts should be combined so that we can win. I think this is enough for.
Madam has already answered everything.
Any question from the audience? I think we've taken most of them. Madam has had an extensive discussion with the panelists, and the panelists have been very elaborate in answering all the questions. So anyone has any questions, comments, suggestions? There was one question which you asked, whether we do DEXA in all our survivors. From the endocrine perspective, we do it. But oncologists usually do it only when they are symptomatic. That's what Amita madam shared, that they do it only if they are symptomatic.
Because we can't wait until the patient becomes symptomatic. By that time, the patient will have the fracture.
So this is probably take home for the oncologist, that you should be doing it annually at least.
Nice to meet you. We
recommend them physical activity, calcium supplement, and also many times actually when we do CT scan, we get to see their spine and things like that, and we get some idea on bone density. So we do give calcium supplement routinely to our patients.
Do you really treat only with calcium, vitamin D?
So
don't you use the other preventive therapies like
So that's
denosumab and zoledronic acid?
Not as a
alendronate?
routine. So suppose a patient receiving letrozole. There we would give zoledronic acid or other things.
You give the backup therapy?
Yes, we do.
Even without demonstrating this
Yes.
thing, documenting?
Yes,
Okay.
we do. Right.
Okay.
Ma'am,
Okay,
I
thank
just
you.
want to make
Thank you,
one point.
everyone.
Like an endocrinologist is a bigger bridge between oncology specialists, because when your patients comes to you, mainly the understanding, communication and liaising between that by liaison about communicating their concerns, and mainly those concerns many times which they don't understand. We have seen this as many times because oncologists are very busy, so patients many times they don't understand how to communicate their problem. Sexual problem mainly because there are a lot of taboo, and then most of the times there's complicated issues about delayed menopause and all. They don't know how to say it. So probably that communication gap can be bridged and education
I think
will
you
help
did
them.
my job of summarizing. That's the purpose that why we are here. We are trying to collaborate, integrate, and get all people of all specialities to handle a patient with cancer.
It's just a teamwork.
So it's a teamwork, and we definitely take this home that we will try and integrate with our oncology colleagues in a better fashion. And Dr. Amita just promised me that she will have a pamphlet for all of us on HRT, which there is so much of clarity now after your talk. So thank you all for the excellent discussion. Thank you, madam, for the excellent
Thank you very
moderation.
much.